Hello, everyone, and welcome to today's session, Latest Advances in Treating Glomerular Diseases. My name is Shazia Lakhani. I am the Senior Director of Clinical Education at AKF, and I'll be your moderator for this session. In this session, we'll cover a few rare glomerular diseases and the recent advancements in treating them. Thank you to Novartis and Travere for their sponsorship of this session. Now I'd like to introduce our session speaker, Jonathan Barrett. Dr. Barrett is a nephrologist and professor based in the UK. His research focuses on improving our understanding of IgA nephropathy. He is the IgAN Rare Disease Group lead for the UK National Registry of Rare Kidney Diseases and a convener of the International IgAN Network. If you have any questions during the session, we have someone in the chat to answer them. And as a reminder, after the session, there will be a general Q&A with our Chief Medical Officer, Dr. Pranav Garamella. At this point, I'm going to hand it over to Dr. Barrett's presentation.
Hello everyone, I'm Jonathan Barrett. I'm a Professor of Renal Medicine at the University of Leicester in the UK, and it's my real pleasure to join you here to talk about glomerular disease. So I don't have anything to disclose, and what I'm going to talk about over the next 30 minutes is try and give you an understanding of the underlying causes and the impact of rare glomerular diseases like focal segmental glomerulosclerosis, or FSGS for short, C3 glomerulopathy, or C3G for short, and IgA nephropathy, or IgAN for short. I hope you're going to learn about the latest research developments and emerging therapies for treating these complex kidney conditions. And hopefully I'll allow you to see how new treatments and clinical trials are improving outcomes and offering hope for patients with glomerular diseases. So let's kick off by going through why these diseases develop in the first place. So if we think about the kidneys, we have two kidneys. They're in the small of our back, and each kidney is made up of 1 million filtration units. And those filtration units are filtering your blood 24/7, every minute of every hour of every day that you're alive. And they're clearing from the body all the toxins that you accumulate during the day. And each of those filtration units is called a nephron, which is why I'm called a nephrologist. And the nephron comprises a filter, which is called the glomerulus, and a tubule, which is a drain essentially, that when the urine is first produced, that tube takes out the things the body needs to keep for itself and gets rid of the toxic substances the body really does need to get rid of, so they pass out in the urine. And the conditions that I'm going to talk about today are glomerular diseases. They're diseases that affect that filter. And you remember there are 1 million of these filters in each of your kidneys working 24/7 to filter that blood and remove all those toxins that you've been accumulating. And they have a very particular structure that's very, very important to how they work. And if that structure is damaged in any way, then you run into issues of the kidneys not working properly and the potential accumulation of those toxins and the development of kidney failure. And so when we think about conditions that affect these filters or glomeruli, we collectively call them glomerulonephritis or a glomerulonephritis, or more commonly now glomerular disease. And there are many, many different types of glomerular diseases. IgAN, FSGS, and C3G are just 3 types. And it may be that you go to a specific glomerular disease clinic, and that clinic will have a special expertise in looking after kidney patients who have diseases of these filters. It's important to recognize that these diseases are not common and that actually they're regarded as rare forms of kidney disease. The most common of those 3 is IgAN, then FSGS, and finally C3G, which we regard as ultra rare. So the rarest of those 3. And what that means is that your primary care physician or general doctors will know very little about these diseases because they just don't see them very often. And actually, nephrologists may well not see many cases of these types of conditions because even with people with kidney disease, they're still not common. And that's why often we find that patients with these types of diseases are looked after by doctors in specific kidney units that specialize in the management and care of patients with glomerular disease. And that's becoming more and more important as we start to see lots and lots of new treatments coming, which is fantastic for patients, but it does mean we need to have a level of expertise in how best to use these new treatments. Now, each of these diseases can only be diagnosed with a kidney biopsy. Some of you may have already had a kidney biopsy, but if you haven't, this is a procedure where generally you lie on your tummy. The kidneys are identified with an ultrasound probe, as you can see in the top left, and a kidney biopsy is taken while you're awake, but with the skin and the tissue numbed with local anesthetic. And we generally take 3 very, very small pieces of kidney tissue so that we can look at it under the microscope and identify and work out what the cause of the kidney disease is and also how advanced it is. And you can see here that the only way we can really evaluate that kidney tissue is through a microscope, and even down to a very, very fine microscope called an electron microscope that can look at individual cells within the filters and work out whether they're affected by disease or not. You have 2 kidneys, and often I'm asked, well, how do we know the disease is happening in both kidneys if you've only biopsied one of my kidneys? Well, through lots and lots of experience, we know the conditions that I'm going to talk to you about equally affect both kidneys. We generally biopsy the left kidney because it's easier to get at. On the right-hand side, the liver is in the way and makes it a little bit more difficult to put the needle into the kidney safely. And so this is what a kidney biopsy looks like down the microscope. You can see here those round balls of cells are the filters. They're the glomeruli. We can see them quite clearly here, and we can look at those and we can look at their structure, and we can identify whether there's any problems or issues there that are causing kidney disease. And the tubules, those pipes that lead out of the glomeruli, you can see cut in cross section as those structures with the hole in the middle, the clear white, which is where the urine would normally flow. But we can see these structures in great detail, and this helps us classify what is happening within those filters and the type of kidney disease that is happening. So in IgA nephropathy or IgAN, when we look at all of these filters, every single filter is full of this protein called IgA. IgA is deposited within those filters, causing a disturbance in how they work, causing inflammation, scarring, and ultimately loss of those filters working properly. And so what is IgA? IgA is an antibody. We all have it. It does a very important job for us in helping us fight infection. But in patients with IgA nephropathy, it is a little bit more sticky than it should be. And when it's sticky and in your blood circulation, it sticks to other proteins, forming big aggregates of protein, and they sludge up the filters. And when they sludge the filters up, they can cause damage and harm. The IgA that we think deposits in the kidneys, it comes from what we call the mucosal immune system. So that's the immune system that lines our breathing tubes, it lines our gut, and it's normally there to help us stop infections getting into the body, but for some reason we don't completely understand, in IgA nephropathy it ends up in the circulation, forming these big clumps of proteins that ultimately deposit in the filters. As I say, the IgA is normally there for a good reason, to fighting bacteria, but in IgA nephropathy, a little bit of this IgA that's normally fights bacteria ends up in the blood circulation. In C3G, the filters are full of a different protein, and that's something called complement component 3 or C3. And here that deposition of this protein leads again to inflammation and scarring of the filters. And this generally forms for a number of different reasons. One, that you might have developed an antibody against the complement system, and the complement system, like the IgA system, is very important in maintaining our health. It fights bacteria, and normally it does a very good job. But in patients with C3G, it's slightly abnormal. It may be because we've got an antibody that causes the complement system not to work so well, or it may be that there's a genetic cause and the complement system isn't functioning properly. And it varies from patient to patient. But the bottom line here is that that complement protein sticks in the filters, causing inflammation and scarring. And then in FSGS, it's a very different process again. Here you can see a single filter, and at the top half of the filter, everything looks good. But in the bottom half of the filter, you can see lots and lots of red staining, and that's scar. That is a scarred part of the filter that is no longer working. And there are lots of reasons why we might see this pattern on the under the microscope. And unlike the other two conditions, where we have a relatively good idea that it's a single type of process that's causing the damage, if you have FSGS, it could be many different reasons for why your filters aren't working so well. It could be that there's something in the blood circulation that's damaging the filters. It could be there's an underlying genetic cause. It could be related to an infection that you might be exposed to, or a drug that you've been given. Or it may be related to the fact that you are overweight or you have high blood pressure. So there are lots of different reasons why you might get this pattern of FSGS. And one of the jobs of a kidney doctor is to try and work out which one of those it might be, because that determines the type of treatment we might give you. What's really interesting is over the last couple of years, it's become apparent that many patients with this type of disease may well have an antibody in their bloodstream that is reacting against cells in the filters, so as an autoimmune disease. And that's important because if it is an autoimmune disease, then we have drugs that are particularly good at targeting the production of these antibodies that are causing the problem. We don't have a test that we can order in clinical practice yet, but that's going to come, and I would imagine by the end of the year, it may be possible for your doctor to order this antibody test to see whether you have these antibodies in your bloodstream that are causing this FSGS. And it's likely we're going to see lots more new antibodies identified that we may be able to test for as well. So if you have FSGS, that doesn't give us the end of the story. That means that a kidney doctor has to work a little bit harder to try and work out which of the potential causes it might have, and that will determine the type of treatment that we might want to give you going forwards. So how do these conditions affect the kidneys? Well, the filters are very good at keeping bloods and proteins in the bloodstream and not losing them into the urine. And when those filters don't work as well, rather like a sieve, those sieve holes can get bigger. And if that filter is damaged, you can start leaking things into the urine that aren't normally there. And the two things that we look for are blood in the urine, and that's called hematuria, or proteins in the urine, that's called proteinuria or albuminuria. Commonest way we detect this is with a urine dipstick. We can also look at the urine under the microscope to see those red blood cells, the blood. And we could always take a urine sample and actually quantify the amount of protein or albumin in the urine. But this is the very early sign that there's something the matter with the filters of the kidneys. But over time, those early changes can lead on to damage and loss of kidney function. And that's when we start seeing other things develop, other symptoms. And so what do the kidneys do? Because if we understand what the kidneys do, we can understand how that might change if those kidneys aren't working so well. So the kidneys are very important in controlling blood pressure. So high blood pressure can damage kidney function, and damaged kidneys can cause your blood pressure to go up. And you can end up with a vicious cycle of high blood pressure, more kidney damage, higher blood pressure. And so if you've ever been to see a kidney doctor, you will know we are obsessed by what your blood pressure is, and we want to keep that under very good control. The other thing the kidneys do, which is very important, is they control the amount of salt or sodium and water in your body. And they control that very carefully so that if the kidneys aren't working and you retain salt and water, then you can start swelling. And the swelling is most commonly seen in the legs, because gravity sends the water wherever is the lowest point. So if you're up on your feet all day, you'll start seeing the swelling appear in your legs. If you go to sleep at night where you're all level, that water will dissipate around the body. And when you wake up in the morning, your ankles are nice and slim, but they start getting swollen the more you're on your feet. So that's something else we as nephrologists will always look at, is whether you have any ankle swelling. The other things, as I've said when we were talking about the kidneys, is the kidneys are very good at getting rid of the waste products, the things that we don't want anymore. Things like potassium, phosphate, and acid. And as your kidneys work less well over time, these things can accumulate. And so on your blood test, the kidney doctors will be very careful to look at your potassium, your phosphate, and your bicarbonate level, which is a measure of how much acid there is in the bloodstream. And then, as well as all of these functions to cleanse the blood, the kidneys are also able of producing important hormones. They produce active vitamin D, so they're very important in keeping your bones healthy. And they produce a hormone called erythropoietin, which helps you maintain your blood count and prevents you from becoming anemic. And what we see is in early signs when the kidneys are in trouble, we'll see changes in your blood pressure, it will go up, and we might start seeing swelling of your legs. It's much later on in the process where we might see the effects of accumulation of those waste products the kidney normally gets rid of. So where we might run into issues with potassium or phosphate or acid, we might see effects on the bones or the blood count. One of the features that we see particularly in FSGS is something called the nephrotic syndrome. And that's the very extreme end of a leaky filter where there's lots and lots of protein in the urine, means the blood protein level falls as a consequence, and you retain lots of salt and water, and you can have quite extensive swelling. It's most commonly seen in FSGS, occasionally seen in C3G, and pretty rare, I have to say, in IgA nephropathy. But it is something that you may well have heard about and you may well have actually suffered from, particularly if you have FSGS. So when we think about these things, we've mentioned the blood in the urine, the protein in the urine are very early signs. They very rarely go away by themselves. We can see development of high blood pressure, another feature, and then we can see changes in your blood tests consistent with you losing some of your kidney function. And we measure that with a blood test called creatinine, and we use that creatinine value to calculate something called your GFR or glomerular filtration rate. And that is essentially a number that roughly translates to the percentage of kidney function you have. So you should have a GFR of 100, so you're 100% kidney function. If it's down at 10, for instance, your GFR, then your kidneys are only working at 10% of what they should be doing. And one of the things that we like to do in patients with glomerular disease is we want to get you involved in your care. So for some diseases, we might ask you to dip your urine to look for blood and protein in the urine, to tell us whether there's a activity of disease, whether there's something we need to change your treatment for. I certainly ask all my patients to buy their own blood pressure machine so they can monitor their blood pressure at home, because that helps me understand whether I've got that control right. And then, of course, you'll often be able to access your blood results and track your own results, track your own GFR, track the amount of protein in your urine. And that's really helpful because it means you get to be involved, you get to see what's happening real time in terms of how your kidneys are doing. But of course, beware, because there are a number of reasons why your blood and urine tests might change that don't mean your kidneys are in trouble. So for instance, if you look here on a miserable day, typically a UK hot summer day, compared to a nice hot day you might have in many parts of the United States, just by getting a little dehydrated, your creatinine level will rise and your GFR will fall. That doesn't mean to say your kidneys have worsened. It's just that you're a little bit dehydrated. So always remember there are reasons why your creatinine might change that don't mean your kidney function is necessarily worse. The other thing is your diet can impact on both your blood creatinine level and how much protein is appearing in your urine. If you have a salad, things are pretty reasonable and reliable. If you have one of those nice American steaks with lots of salt, you're likely to see a rise in your creatinine and you're likely to see more protein in the urine. Doesn't mean to say your kidney function's changed, it's just a reflection of what you've been eating. So just be aware if you start taking an interest in your results, there are other things that could make those results change that don't necessarily mean your kidney function is in trouble. And then you might well also hear about changes in kidney function over time. And so we stage kidney disease, CKD stage 1 through to 5, and that's based on your GFR value. So GFR above 90 is CKD stage 1. If you have other changes, between 90 and 60, it's CKD stage 2, 60 to 30, CKD stage 3, 30 to 15, CKD stage 4, and below 15, CKD stage 5. And so when we start thinking about that time of transition to dialysis, it's normally when the kidney function is below 20. When the GFR is below 20, approaching 15, we like to start the conversation about what we need to do if the kidney function continues to get worse, in terms of what type of dialysis might be right for you. And that could be hemodialysis, that could be peritoneal dialysis, but importantly, we also want to start thinking about kidney transplantation, because in a perfect world, we would perform a kidney transplant before you ever saw a dialysis machine. Everyone's kidney function gets worse at a different rate. Some patients' kidney function never gets worse, others get worse quite quickly. And this is where it's important to work with your kidney doctor to understand for you what is happening in terms of the rate of change of your kidney function, because that will help you plan what is likely to happen in the near and medium future in terms of potential risk for dialysis, potential need for a kidney transplant. So that's the background. But what's really fantastic at the moment is we are seeing so many new treatments coming along for these three conditions. And they're really looking like they're going to be transformative in terms of slowing the loss of kidney function, and potentially even stopping the risk of kidney failure forever. And so what I'm going to do now is just talk through the basic principles of what these drugs do. So first of all, we need to think, what are we treating? Well, of course, we want to treat the actual disease, those diseases processes that I talked about, these antibodies and the IgA that deposits in the kidneys, the C3 that deposits, the potentially autoantibody that causes FSGS. We want to focus on that, absolutely, and we've got lots of new exciting treatments for that. We also need to understand that as kidneys start getting worse, there are some general processes that happen in all forms of kidney disease that need to be addressed as well. And that requires a different set of drugs, and I'll talk about that. And then, of course, we always need to think about those other things that can make kidney failure happen quicker. It could be obesity, it could be diabetes, it could be uncontrolled high blood pressure. So all of these things are the things going through my mind when I'm seeing a patient, is how am I treating the disease? How am I treating those general things that happen in kidney disease? And does the patient have anything else that might be making that kidney disease deteriorate faster? So when we think about how we treat the actual disease, we have lots of new exciting therapies to target the production of antibodies that cause kidney disease. IgA nephropathy is driven by those IgA antibodies coming from predominantly the gut. So we have a new treatment that actually slows down the production of IgA within the gut, very specific to IgA nephropathy. But we also have treatments now that target the cells that actually generate antibodies, and these are called lymphocytes. And we have lots of new exciting treatments that can either gently turn down the activity of these cells and slowly reduce down the production of these antibodies, so that they don't deposit in the kidneys. Or we can actually go around and just kill these cells using agents that are often used to treat cancer patients. Not that these diseases are anything to do with cancer, but they're highly effective at killing cells that produce these antibodies that get into the kidneys. And the choice of which of these we might use will be very dependent on the type of disease you have and how quickly it's changing. And this is something you would want to discuss with your kidney doctor. How do I get rid of that antibody that's causing all the trouble? And we've got lots of new ways of doing that. Really exciting. The other thing, which has only just been a thing that we can do in clinical practice, is we can block the complement system, the system that actually is the main driver for C3G and a few other diseases. And we've got lots of new ways to do that safely and effectively. And this is just the beginning. I could spend the next 6 hours talking about all the new therapies coming in glomerular disease, in all the different glomerular diseases. And I wouldn't have even touched half of the things that are happening in terms of new opportunities. So if you do have one of these diseases, make sure you speak to your kidney doctor about what's available at the moment and the opportunity of being involved in the clinical trial, because there are lots of wonderful new treatments that are being tested in clinical trials at the moment. And then for all those patients who have kidney disease, what can we do to generally protect the kidneys in addition to those very specific treatments? So when you think about how the kidneys work, if we start off with 1 million filters and we suddenly go down to half that number, half those remaining filters are now having to work very, very hard to do the job of all the filters that have been lost. And when they work harder, they get more fragile and they become prone to break. Just like you can imagine in any system, you have to work twice as hard, you're more likely to pick up injuries. And so there are a whole series of drugs we can now use to kind of take the strain off the overwork of those filters. And so many of you may be on a what we call a renin-angiotensin system inhibitor, ACE inhibitor, drugs that end in pril, like ramipril or enalapril, an angiotensin receptor blocker, drugs that end in sartan, losartan, valsartan, candesartan. The new kids on the block, the SGLT2 inhibitors, the gliflozins, terrible to pronounce, so dapagliflozin, empagliflozin, and then the endothelin receptor antagonists that are being used as well, endin-entan, atrasentan, sparsentan. These are drugs that take the pressure off those overworking filters and are suitable for many, if not all, forms of glomerular disease. And you may well be on a different combination of these, I'm sure. And then finally, how are these new treatments and clinical trials improving outcomes? Well, I'm just going to touch a little bit. This was what my life was like as a kidney doctor, a glomerular disease doctor, for around 20 years. I would go to the drug cupboard, I had nothing, and nothing seemed to be changing. But that has completely changed in the last 5 years. Now I have lots of options and many, many more coming. And in fact, it's overwhelming how many different ways I can treat glomerular disease now. It is so exciting. You can't go to a kidney meeting without hearing new data from a clinical trial about yet another treatment that is working well in patients with glomerular disease. And so we have lots of ways, as I've said, of targeting those antibodies that cause so much damage in the filters of the kidneys. And here's just one example. If IgA nephropathy or IgAN, what you can see here is if we target that antibody production, we can reduce the antibody that we think causes the problem, and here it's called Gd-IgA1 for IgAN. But when we do that, we reduce the amount of blood leaking into the urine, the hematuria. We reduce the amount of protein leaking into the urine, the proteinuria. And what we're starting to see is that reduction in protein, that reduction in blood, means the glomeruli, the filters, are becoming healthier, and we're seeing a slowing down of the loss of kidney function. And in some cases, we're starting to see that actually the loss of kidney function is returning to what you might expect for a healthy person. So this is really exciting. These are things I didn't think I'd see in my career. And we're now starting to see this with a range of new treatments that target the antibodies that are depositing in the filters and causing all that damage. How about targeting the complement system? Again, a challenging thing that we haven't been able to do effectively for a long time. But here's just one trial where we see, if you look at the pictures of the kidneys, the filters, you will see a very bright green filter that's full of that C3 protein. Now in C3G, most patients would inevitably end up on dialysis, and if you were lucky enough to get a kidney transplant, it would inevitably come back in that kidney transplant and cause the kidney transplant to fail. What we see here with this treatment is the before picture, that filter full of the green glowing C3, and after 6 months of treatment, all that C3 has disappeared. There's nothing in the filter at all because the patient has had another kidney biopsy after receiving the treatment. Something that is incredible when we think about the challenges we've faced managing this disease in the past. And on the bottom, what you can see here is the amount of protein leaking into the urine. So that goldy coloured line is patients who got the drug to begin with, nice reductions in protein maintained over the full year. The grey line is those that got the placebo, so the dummy drug, no change because we weren't giving them any treatment. They switch over to the treatment and the protein just drops down beautifully. So we're now able to really intervene and protect those filters by stopping that C3 protein depositing within the filters and causing damage. So of course, with this great advance, with all of these new treatments, it is becoming quite challenging. If you're a patient listening and you go and read up about these new treatments, you will be confused by how many options there are. And that's just the same for kidney doctors. We never had much choice in how we treat these conditions. We now have lots of choices. So the big challenge for us is how we decide the right drug for the right patient at the right time in their disease. And this is something we're going to be working with and working on over the next 5 to 10 years. And we're going to be thinking, is it a single drug that might work for a patient, or do we need to combine these new treatments? All of these are going to be things we're going to be thinking about going forwards. But for the very first time, we actually have treatments that we can use to get patients' disease under control. So there are big, big changes ahead, both in how we think about these diseases, but also how we treat them. And if I can finish, I want to finish on this. The future is exciting. For many, many years, if you had IgA nephropathy, FSGS, or C3G, the outlook was bleak. There was a real chance you were going to end up on dialysis in your lifetime, and there was a real risk if you had a kidney transplant, the condition was going to come back. I think those days are long gone. I think with all of the new treatments that we have available and are coming, we are really going to be able to get the disease under control in most patients. And the likelihood of patients needing dialysis in their lifetime is going to get smaller and smaller and smaller. It is a wonderful time to be a kidney doctor when I have so many new treatments to offer my patients. And while it's not good to have a disease, it is a wonderful time if you have to have FSGS, IgA nephropathy, or C3G to be a patient, because we have so many new treatments that we are going to be able to use to get your disease under control. So I hope you found this useful. It's been a real pleasure joining you. And I hope if you do want to find out more, please investigate, contact the NKF or the various patient foundations that will help advise and guide you, and enjoy the rest of the conference. And thank you for listening.
Thank you, Dr. Barrett, for this engaging overview of glomerular diseases and treatments. And thank you all for joining us today. I'd like to thank Novartis and Travere for making today's session possible. Up next is our Q&A with the American Kidney Fund's Chief Medical Officer, Dr. Pranav Garamella, starting at 2 p.m. Eastern Standard Time. During this session, Dr. Garamella will answer questions across any topics we've covered this week. And as we wrap up this session, you will see a brief survey pop up. Please take a minute to fill it out and tell us how we did. Your feedback will be very useful as we plan future sessions. Thank you, everyone, and have a great day.